Okay, you have to unmute.
Got it. Why don't we go ahead? You want to get the first PowerPoint up and running? Tim, you're on first. Why don't we get yours ready to go?
Okay.
You're making sure you put it in full screen mode for me.
Hi everyone, thanks for joining. We're just waiting while our participants get signed on before we started.
Yep, we're at 250. So let's just check out when we get to about 500. Check. I'll let you know, and we'll get started. Perfect. That looks great, Tim. Thank you so much. So welcome to the webinar, everybody. Super excited about going back to work. So we are going to be giving you some great information today, and I have some very I can say good friends and experts in the field, and I know that there's a lot of questions out there about what's going on, and we're going to do our best at Benco to really help support you and answer a lot of those questions. So I am super excited to be on today with what I think is some of the finest people out in the dental field that really give everything every day, their heart and soul, to make sure that you're taken care of and that your teams are taken care of. So really good webinar today. We have some HR and some infection control information going on. But like I always do, I love to open it up, and I love to give Chuck Cohen, the managing director of Benco, the opportunity to give us an update on where the supplies are, because I know that's a big concern as we're going back in, but I know Chuck has some amazing answers. So Chuck, you want to give your Benco family an update about what's going on?
Absolutely, Kay. Thank you very much. So welcome, everybody. We're glad you're here. The most interesting and the most questions we get these days are about personal protective equipment. And we're going to talk about that a lot today. Clearly, the supply chain has been challenged over the past few weeks, and we're seeing that as much as anyone has. The main thing we want to say is we are working as hard as possible to get the products that everybody needs in order to get back to work. We've been working closely with our current supply partners and also looking for new ones. And we've also seen a lot of counterfeit products out there. And the warning that we want to give everybody is of all of the leads that we've chased down, right? There's been no shortage of counterfeit products that have come up. We've chased them all down, and we figured out that there are a fair number of counterfeit stuff, a lot of counterfeit stuff out there. So we'd encourage everyone to buy from trusted suppliers whenever possible. We understand the prices are going up, and we're trying to protect against that as much as we can. So Kay, that's our quick report. Thank you for having me today, and look forward to a great event.
Fantastic. Okay, so, you know, when we start the webinar off, I always like to make sure we go over like the guidelines that we need to follow to make sure that you get your CEs that we promise you. So I am going to go over a few of the guidelines. If you miss them, don't worry. I will go over them again at the end, and we'll also give you the PowerPoint with the link that I'm talking about. So number one is, if you registered for the webinar today, we need to make sure that you used your legal name. And what I mean by that is the name that is on your license, that when you have to send in your CEs, make sure that you registered in that name. Sometimes states are a little bit funny about that, and they really require that you give your legal name on those. So if you didn't do that, don't panic. We'll take care of you. Just send us an email to practicecoaching@benco.com, and we'll be more than happy to make sure that we change that name. The next thing I need to let you know is that if you are wanting CEs and you did sign up, each person needs to make sure that they register or sign on to the computer on their own device. This is being monitored by our amazing CE person, Maria, and we'll be able to see when you sign on and when you sign off. It's very important that if you're wanting the CEs that you stay on for the entire time so that we're able to give you those CEs. So if you're logging on a telephone, you're fine. If you are dialing in on a telephone, we don't see those. So if you're dialing in on a telephone to listen to the webinar today, what I ask that you do is to please send your name, the title of the course, and your telephone number to practicecoaching@benco.com, and we will make sure that we get you your CEs. Again, if you're dialing in to listen, you can listen from your cell phone and push join. That's perfectly fine. But if you're dialing in, please make sure you send us your name, the course of today, and your telephone number to practicecoaching@benco.com, and we'll make sure that you receive your CEs. I also want to point out at the very bottom of your screen, there's a Q&A. It's called Answer and Question. So if you have questions during the webinar, please make sure you type those in. We will do our very best to make sure that we answer all the questions. And I will say this, Leslie and Linda, when they did some research, they've done a lot of these webinars for the infection control. They've received tons of questions, and what they did was they gathered their top questions, and they're going to make sure during the webinar that they will be covering all of those questions for you. And we will have some time, but a lot of our time is going to be spent on what's out there for today. So with all of that being said, I get to do what I call my favorite part of this whole program, and that's introducing who I think is an amazing boss, and someone who's actually been on top of this and really and truly kept his team on top of it so that we can make sure that we take care of our Benco family. So with that being said, I'm honored to introduce Chuck Cohen, Managing Director of Benco Dental. Chuck, you on?
Hello.
Hold on one second. Chuck, are you on, Chuck? Okay, well, let's move on. So we have three speakers today. I'm going to go ahead and let Tim Twigg get started. Tim Twigg is our manager. Tim Twigg actually is our partner with HR, and Tim helps a lot of practices understand what the rules and guidelines are for HR. So Tim, with that being said, why don't you take it over?
Thanks so much, Kay. So we're talking about the road to recovery, and it's really about, let's get focused on being successful. My slide here is just delayed for just a second. So as we get going here, we're going to be talking about a lot of things from an HR perspective in terms of what's required and necessary as you move forward. And it's both right now, and then it's what to do next, and then sort of an action plan. And when we're all done, you really will have an action plan that's going to support your ability to move forward in hopefully a more systematic manner to allow yourself to be successful. And I'm just skipping a little time here, or taking a little time here till the screen picks up. So
hold on one second. Is it working? So let me see if I can get one of our Benco helpers, Leah or Donna. Can you help us out here?
Yeah, so Tim, the only suggestion I would have is maybe stop sharing your screen and then restart sharing it again, and let's see if that helps.
So guys, as we do that, I know Chuck came back on. So Chuck, while Tim's doing that, did you want to introduce the three speakers today? I did a little brief introduction, but I love your introduction. So would you like to tune in while Tim's getting signed on? I don't know if he's on.
I'm having, can you guys hear me?
Yeah, we can hear you. Go ahead.
So more important to the three until all of our presentations, all of our webinars.
Okay, guys, I can't hear Chuck. Can anybody hear Chuck?
No, Tim, can you go ahead and get your slide up and keep going?
yep, here we go.
Let's go.
So in anticipation of reopening, hopefully you've called and scheduled and rescheduled your patients to make sure that you've got a full schedule.
Are you going to share your slides, Tim? Are you going to share your slides?
Yeah, so it's goofing up again, huh?
You know what? This is live, right? This is who we know we're giving out good stuff when we're coming live. It's okay. We'll get it up. If we have to go over a little bit, that's perfectly fine. I want to make sure we get out all the information to everyone. So breathe and we'll make it happen. No stress. I don't know if Donna can take it over. Does she have your copy of your PowerPoint?
No, we do not have his PowerPoint, so we'll just wait for him to get it back up. Is it not letting you share your screen, Tim?
Correct.
If you want to email us your PowerPoint, we can control it from our end while you just talk, and we'll catch up to you. If you want to email it quick.
I will be back on.
I think he's going to re-sign in. So
Perfect.
everyone just be patient. It's all going to come back. This is what happens when you do live webinars, right? Right, Leslie? I guess Leslie and Linda can tune in with me a little bit, correct?
That's right. When you're live, you have to deal with the internet and the bandwidth, and there's so many people conducting live and remote meetings right now that there's a lot of traffic in cyberspace.
Thank you guys for coming on. And I think what Tim's going to be doing is he's going to be re-signing in. Hey, Rick, you can join in too a little bit while we're waiting. So
Okay, I can tell you about tomorrow. Tomorrow, tune in tomorrow. It is tomorrow, right?
Tomorrow
We're
is
gonna
you,
talk
Rick.
about,
Cohen.
that's right. We're going to talk about the complexities in the PPE marketplace. I think that everyone will find it very interesting, and I would highly recommend tune in tomorrow. You'll learn a lot about PPE, stuff you never even knew you wanted to know. So I look forward to it, and I think you're going to have a great time.
Well, thank you for jumping on. I think we're backing up and running again. All right, Tim, you want to take it over?
I do.
You got it. You are on.
Okay.
All right, guys. Thank you.
Okay. So as I said, in anticipation of reopening, hopefully you've called and rescheduled patients so you've got a full schedule. You've also supported your employees and your patients through communication, through the closure and the layoff. And then hopefully also you've used that time really well to take advantage of some of the CE opportunities that were out there to learn, to grow, and to improve, and also do some cleanup there at the office. Now, what is your biggest challenge now? The biggest challenge as you look at this whole idea of reopening is balancing all the moving parts. And when you think about it, there is just a whole slew of moving parts, and they are all mushed together. See, if you had a pipe break in a hygiene operatory, you turn off the water, you call the plumber, everyone mops up the water, you fix the pipe, and you're back in business that afternoon, or maybe at worst case, the next day. And depending upon how your pipes were, other operatories stayed up and running this whole time. But in this case, there are grants, there are loans, there's PPP forgiveness, there's state and local mandates, there's the FFCRA, there's all the goofiness with unemployment. There's people's concerns and worries, and then a whole slew of new normals. And all of these have to be navigated now, all at the same time. Relative to reopening, I think there are three primary objectives that you really got to keep foremost on your mind. The first one is anything and everything you can do to minimize the risk of contamination. And this is before treatment, during treatment, and after treatment. You've got to instill a sense of confidence and safety for the health and well-being of everyone, and that includes primarily your employees and the patients. And the third absolute key priority is to make smart, wise, prudent business decisions. And really what that means is don't rush this. Be smart and focus on success. Now, relative to focusing, I want to touch on two things that I'm going to say don't focus on. And unfortunately, it's a thing that a whole lot of dentists are focusing on right now. But there are two things I think that can end up being a pretty significant distraction as it relates to your long-term success. And the first one is this PPP loan forgiveness. Folks, it's just a loan. It's got super terms with it, but it's just a loan. And the money can basically be used for anything. So be smart about your PPP loans. Cash is really king right now. It is not loan forgiveness that should be dictating or directing the decisions that you make. Now, relative to loan forgiveness, I just want to touch briefly on some of the key provisions of it. Most of you know these. One of them is the money has to be spent within 8 weeks of the funding. The second one is at least 75% of that money has to be on payroll. And then the remaining, there are certain approved expenses. It's important to note, as that footnote says, that for loan forgiveness, these are bills, so to speak, payroll and other bills that were incurred during the 8-week period, and they were paid during the 8-week period. So you don't get to go backwards and pay bills from the past, and you don't get to pay bills in advance. The wages that you're paying out on June 30th have to be at least at the 75% level or higher than what they were on February 15th. Or when your 8 weeks ends, whichever is sooner. And then this is the one that potentially will trip up a lot of people. The full-time equivalents, or your FTEs, on June 30th have to be 100% of what they were on February 15th. Now, the bottom line to this is loan forgiveness is not guaranteed. And what do I mean by that? It's not just a matter of these items that are listed here. It's that the SBA has yet to issue their final guidance with this. They were supposed to come out with it on Monday, and they still haven't. In fact, Secretary Mnuchin today was saying that depending upon the size of your PPP loan, forgiveness will also include an audit of all of your books or a deeper spot check of your books. So to wrap your head all around this forgiveness thing, again, to make choices and decisions predicated solely on loan forgiveness doesn't make a whole lot of sense. I think it's more instructive to ask yourself this question. If I got a PPP loan and it didn't have any of the forgiveness provisions in it, what would I do? And what we're finding is a whole lot of dentists would then say they would do something very different than what they're attempting to do right now when they're being sort of guided or driven by this obsession about loan forgiveness. The other thing to not spend a whole lot of time focusing on is unemployment. I get there's a wrinkle right now. I get that there's this extra $600. Just know that it ends July 31st. Now, eligibility for this is if unemployment benefits are just $1. So why not employ your people? Go ahead and employ them maybe on reduced hours that doesn't consume all of the benefits they would otherwise be receiving. And in that case, the employee qualifies for unemployment, the employee gets the $600, and the employee is still working for you. And there's some progress you can make in terms of moving forward. So there are some real strategic ways to actually work with unemployment as opposed to just be freaked out because people are getting this $600. So in terms of your action plan, and I said at the outset that my goal here is that you will come away with an action plan. We're going to focus on your action plan from 3 perspectives. And one is things to be doing right now, and then sort of the next category of things to be focusing on, and then what to focus on in terms of moving forward. And again, I just want to remind you that I think from a prudent business owner perspective, it's like, don't rush, be smart, and focus on success. So the things to be looking at right now, FFCRA, which is the Family First Relief or Coronavirus Relief Act. There's compliance issues associated with right now. There are posting issues. This went into effect April 1st. So what that means is as soon as you reopen, then FFCRA compliance rules and regulations are going to land in your lap. The bad news about FFCRA is that it doesn't expire until December 31st. You are not exempt. And initially there was a 30-day enforcement grace period, and that's now over. So there was a report just early this week about a business down in Tucson, Arizona, who has already gotten hit with a claim and a violation and having to pay because of not being in compliance with FFCRA. The second piece around bad news is that, oh, my screen is decided to go slow again. There we go. The second piece about bad news is that the odds are between now and the end of the year, there will probably be some COVID-19 outbreaks, which may prompt some school closures in the fall or some closures again of some childcare facilities, which will most likely prompt leave requests. And so it's important for you to be on top of this and know what's going on. There are some posting policy and forms requirements that will ensure success. That's sort of the bad news with it. The good news is it does expire on December 31st. And so unless Congress extends it, then we have a window here of just a little over 6 months where this is going to be at play. The good news is relative to qualifying for the sick leave or the family leave aspects of this, there are limited and very specific qualifying reasons. So this just isn't some big open closet up to anything and everything. And you are reimbursed 100% for any monies that you pay out for the sick leave or the family leave. So the bottom line is it's really not costing you anything. In terms of the qualifying reasons, we reviewed these in a couple of other webinars that we did. These are the big key 6 qualifying reasons for the sick leave or the family leave. Relative to these, all 6 represent qualifying reasons for the sick leave, but it's only number 5 that represents a qualifying reason for the family leave portion. Relative to compensation, if the qualifying reason is 1, 2, and 3, the person is to receive their normal wages up to $511 a day. If the qualifying reason is 4, 5, or 6, then the compensation while on leave is 2/3 of their normal pay or up to $200 a day. In terms of amount of leave time, just real quickly, sick leave, it's up to 80 hours. It's prorated based on how many hours a week the person works. And on the family leave side, it's up to 12 weeks, although the first 2 weeks are unpaid. And again, it's prorated if a person does not work 40 hours a week. So there's clearly some updating that needs to happen with your policy manuals and with your employee handbooks. There's some updating of job descriptions, and there's absolutely some updating of your standard operating procedures to ensure compliance with the regulatory requirements of FFCRA. The next thing to focus on right now is basically an inventory of your team. This is not an inventory where you're just asking people whether they're ready to come back or not. This is like a more in-depth inventory of your team. And I'm going to suggest that you take a piece of paper and you create 4 columns, not unlike what you can see here on the screen. And you have the names down the left side of each of your employees. And then you rate each of your employees on a scale of 1 to 10 for their competency. So this is competency of the job they are expected and they have been hired to do. This is not whether you like them or not. This is just about their competency with respect to the job that they have been hired to do. Then rank them on a scale of 1 to 10 relative to their people skills. There might be someone who has amazing people skills and just isn't very good at the job. There could be someone who's really good doing their job, but they don't have great people skills. So again, rate people skills on a scale of 1 to 10. And lastly, rate these people on a scale of 1 to 10 relative to their attitude. And from an attitude standpoint, this is your definition. It's not my definition of a good attitude, it's yours. So now you have this census, so to speak, or an inventory of your team. My contention would be that anyone who ranks like a 7 or below, maybe that's not a person who ideally would be in your practice. With the following footnote: competency and people skills are things that can be trained. That's what Kay Huff and the rest of the practice coaching team at Benco really focus on. So competency and people skills are things that can be taught and learned. Attitude, on the other hand, is not something that you can teach. So you are going to be faced with an issue of who's coming back and who's not coming back, who wants to come back, who doesn't want to come back. And this might be a really helpful guide to also stir into the mix relative to this. So again, who's coming back, who's not coming back, and are there any conditions that employees might be putting out based on their interest, desire, or willingness to come back. Now, this is also going to lead to you right now needing to spend a little time thinking about your staffing levels. When you go to reopen, your reopening is going to be a phased reopening, or it's going to be not phased. Most of you, odds are, just the nature of everything that's gone on, is it's going to be a phased reopening. So then it's a matter of thinking about what is my staffing level when I reopen? What is my staffing needs at each of these phases, sort of the who and the when of this? Clearly, staffing levels should correspond to revenue. Circling back, staffing levels should not correspond to PPP forgiveness. It should correspond to revenue and the business level that your practice is at. Now, due to the economic conditions, you may have to restructure some things in your practice to accommodate or work with new normals, which may result in not employing as many people as you did when this first thing all came down. It may mean changing some job duties and expectations. It may be reducing hours or pay. You just have to look at what will really support your long-term success and the financial stability of the practice. And no doubt, with a lot of the new normals, procedurally, clinically, administratively, things are going to take more time before, during, and while you're seeing patients. And that has to be also stirred into the mix as it relates to staffing levels. So if I've done an inventory and I've also thought through these different phases and staffing levels, now I can come to this point of actually thinking about reemployment. When you start thinking about reemployment, then for the people who used to work for you, were they let go or stopped working as a result of a furlough? Which means they did stay working for you. And in bringing them back, then if nothing's going to change, you have a reemployment letter. If something's going to change, you make sure that you document what that benefit or status change is. Some of you may have let people go and you called it a layoff, but you still kept them employed. Same sort of thing. If there's no changes in bringing them back, then simply the reemployment letter. If there are going to be changes again to working conditions or wages or benefits, then you've got to make sure that you document that. If in the layoff that you did, the person did not stay employed, which means for all intents and purposes, the employment relationship ended, and now you're going to bring them back. If you're bringing them back under the exact same terms, conditions, compensation as before, then a reinstatement letter, and you then pick up where you were going from there. If things change, a reinstatement letter with all the appropriate paperwork. If it was more of a permanent layoff or a termination, and now for some reason you are deciding to bring that person back, then again, you follow the similar sort of guidance, but in this case, for all intents and purposes, it represents a brand new hire. So in looking at reemploying, the reality is some are going to be coming back now, some later, and potentially some not at all. And that's the reality of where we're at. Even though that's the reality, it's really important to keep in mind, again, that you must make smart business-related, objective decisions about this. The pandemic, the furloughs, the layoffs do not let you get off the hook with all the various rules around people's protected classes and status. Certain individuals may not want to come back, and that's also a reality. In that case, you as the employer have got to have an interactive conversation with this employee to really drill down to the reason that they're choosing not to come back. When you think about reasons, here are some of the reasons that you might hear. Maybe a state and local mandate. That's a very, very valid reason, because right now we're in a real wacky situation where some states are saying dental offices can open, but at the same time, the state still has a stay-at-home or a shelter-in-place mandate in place. And really, when it's all said and done, those two things absolutely conflict with each other. Again, you look down these various reasons or some other aspects associated with this person, all of this has to be sort of talked about and communicated so you are clear about the reasoning for this person choosing not to come back. If it turns out that all the answers to every one of these is a no, well then maybe it's time to move on and you let this person go. If the answer to any one of these is a yes, then you cannot just summarily terminate or end this employment relationship. At that point, we suggest that maybe you take advantage of an employee reinstatement process guide that we have created. You can email us at info@benterickson.com and request it, or you can actually just log on to our website using that link and you'll be able to have access to it. It will support your ability to more systematically work through this rehiring process and what your options are. So in terms of right now, where your focus should be, FFCRA compliance, updating policy manuals, job descriptions, and your SOPs. Then drill down into what is the best and most strategic plan for reopening. And with that, this inventory of the team and staff levels, looking through reemployment, who's going to come back, and to the degree as is needed, then new hiring to fill vacant positions that you have. These are the things for your time and energy to be spent on right now. And once you've gone down through those, then you set your reopen date. Most of you, because the state said you can reopen, you just assume you can reopen. It's putting the cart before the horse. It's once you've done all of this review and this analysis, then taking into account these various factors, you set your reopen date. Once you have a reopen date, then what do we do next? Well, in an ideal world, 1 to 2 weeks before reopening, you start having team meetings. And in these team meetings, it's to discuss and plan and practice and role play new normals. For all intents and purposes, everything is going to be different in terms of the flow and how everything transpires in the practice. And so even though some number or even all of your employees that are coming back are existing or former employees, you have to think about this almost as if everyone is a new employee, because we've got new processes, new protocols, and new procedures that are going to be impacting virtually every aspect of the practice. Things like paperwork. Is the paperwork going to be done online? Is it going to be done in a separate room that has been designated just for this? Does the patient fill out their paperwork in the car? You give them a pen, you give them the paperwork, maybe you gift them the pen to say thank you so much. What about hand sanitizer the moment someone walks in? Could be just a message to say, we take your health seriously. And the list goes on and on about new normals, things to consider, things that will be changing. So you cannot just set a reopen date and think that on that day, everything will simply pick up and go back to the way it was. If you note on the list, there's temperature checking. And there's a lot of questions that come up. Can I take my employees' temperature before coming to work? Well, I'll give you two answers. One, the really short answer is, yes, you can. Now, here's the other answer. Checking someone's temperature is compensable time. So if you have 30 employees and they're all sort of standing in line to get their temperature taken, for however long that's going to take, 15 or 20 minutes, everyone's on the clock for that 15 or 20 minutes. In addition to that, if someone's temperature is above the 100.4 degrees and you choose to send them home, depending upon the state you're in, you'll be obligated for what's commonly referred to as show-up pay or reporting to work pay. And that depends on the state. If you're in Alaska, Alabama, Virginia, Texas, they say we have to pay the person just for the amount of time. But if you're in a state like California, you have to pay a minimum of 4 hours, or what represents half of what their shift was otherwise going to be. Then, if you're thinking about taking temperatures, you also have to bear in mind that the incubation period for COVID-19 is apparently around 2 weeks. And so someone could have a temperature below 100.4, be asymptomatic, and yet they still have COVID-19. And so how is the temperature check piece really helping you? You could ask people to take their temperature at home and be on sort of the good buddy system of doing it themselves, good faith effort, and you can do that. Doffing and donning of uniforms or scrubs or gowns is also going to be compensable time as we move forward in this. So there's a lot of changes in the works. So right before you reopen, again, 1 to 2 weeks before, team meetings, discuss, practice, role play, run through things, rearrange your reception area so social distancing is in place. What is the flow of patients through the practice? Kind of enter and exit to minimize things. How are you going to collect payments now when people in the clinical area aren't supposed to come up to the front business and administration area, and vice versa? So now we get to a point where we really get to move forward and we really get to open. And what I'm going to suggest is that you spend some time thinking about improving overall leadership. Right now, up until now, everything has been more like crisis management. But as you move towards reopening, it really does become a leadership piece, and showing how you are going to sort of guide this ship moving forward through these turbulent waters to be more successful. And back on that, some of that is, what is your reputation as an employer? Because the reality is those employers with a great reputation are going to be the ones who are going to have an easier time in the hiring process. Better hiring, again, you look first for attitude and fit. You look for experience and skills second, because those things can be taught. And remember again that employees are going to be looking for where it is safe and where there might even be some flexibility in their work schedule or routine. I mentioned earlier that in terms of re-employing and hiring, this is almost as if every single employee is a brand new employee. And so onboarding becomes critical. And onboarding even is changing because of some of the requirements around social distancing, which is where having computerized online SOPs becomes even more critical, because now the training can happen in a very comprehensive and sophisticated way, online and digitally, without the sort of shoulder-to-shoulder training that is otherwise most typical. Think about ways to improve communication through recognition and appreciation, managing performance more from a goal setting and goal monitoring way, as opposed to the old traditional once a year performance review, and then supporting employee engagement so that we're really working on having more this idea of stakeholders that Chuck Blakeman talks about than having just employees. The other part about moving forward is it's not too soon. It's not too early to begin thinking about how I can be better prepared next time. It was being unprepared and the lack of preparedness that caused a lot of fear and anxiety and confusion. So now is the time to develop a plan and look back over the last 2 to 3 months and ask yourself some of these questions. What was asked of me? What did I not know? Where was I caught by surprise? What was missing? What questions did my employees ask, and where was I stumped on those? How could I have communicated better? What should my employees know before this happens again? And most importantly, what do I need to do to be better prepared to confidently address and handle the next one? All of this will lead to creating a comprehensive plan. And then, of course, you need to communicate that plan. So in terms of moving forward, leadership, better hiring, onboarding, communication, the idea of really learning from your mistakes, developing a comprehensive plan, and communicating that plan. This is a business, the dental practice, and it's about truly being smart about how to strategically position yourself for success moving forward. So I'm going to turn this back over to, I think, Kay and Donna, who are going to field questions, and I'll also look at them also. You're muted, Kay.
Always good to unmute, right?
Yeah.
I wish I had one of these at home. I could just like mute and only listen to what I want to hear. But so yeah, we do have questions. So let's go over some of the questions, and I hope I'll try to get as many as I can. So number one, it says, if he's in Michigan, but nonetheless, you know, he was actually going to do what they call a soft offer, which that means they don't bring everybody back full time. How would that work?
Well, it's the same sort of thing. It's a soft opening is really just sort of like a phased process. And so then it's a matter of inventorying the team members and then doing an analysis of staffing levels during this ramp up or soft opening phase. And then you offer employment to those where it's appropriate and you have need for people, and the others are still furloughed or laid off until the next phase.
Okay, and so I'm gonna try it because there's like 3, and I think they all ask the same question. So it's really regarding to see what are the posting requirements for the FFCRA, and where can I find it? And then another one says, I was under the impression that healthcare providers were exempt from the FFCRA. So I don't know if you can address both of those together.
Sure. Sure. So first of all, FFCRA stands for Families First Coronavirus Relief Act. You can find out a ton of information about it on our website. There's a link on our website also to the poster that you have to have posted in your practice, as well as an explanation of the provisions about it. Relative to exemption, there's all kinds of misinformation running around out there about exemption. Here is the bottom line. Is there a blanket exemption for employers who have less than 50 employees? No. Is there a blanket exemption for dentists or hygienists as healthcare providers? No. That is only for people in the medical field and first responders, and the way all the definitions are, dentists and hygienists do not land in that category for this exemption. Now, that all being said, there is some language in the whole provision that does talk about exemptions. The exemption is only for qualifying reason number 5, which is child care, taking time off to take care of a child when schools or daycare centers are closed. That's the only place where there might be a possible exemption. And then you have to look down some criteria, like you're going to have to basically swear that to comply with this for this person who needs to be at home to take care of their child is going to jeopardize your business. Like you're going to go out of business because of doing this. That's going to be a real hard one to prove because the government's reimbursing you for any money, so there will be no financial impact of it. There are a couple of other reasons that come into play, and it's like you can't find someone else to replace this person, or this person is so integral to your practice that you cannot ever practice without this particular person. Those are just going to be so hard to actually prove or justify. And the last little piece about exemption is this. Even if you had a circumstance or a situation with a given employee that you truly felt you were exempt, the exemption is only for that employee and that particular situation. Every situation then has to be looked at on a case-by-case, employee-by-employee basis. So do not think that you're exempt and you get to just not worry about that. It's absolutely not true.
Okay, and so this is a really big one. I've been getting this question a lot. Number one, it says, can a pregnant employee that does not feel comfortable with working stay at home and still collect the unemployment after we have brought the rest of the team back? That would be one of the questions. And another one to go along with that is, again, what if you have an employee that says, well, hey, I want to stay home and collect unemployment a little bit longer. Do I have to come back? And what if they use that fear tactic? You know, can you at that point let them go?
Well, we go back to the list that I had on there earlier about the reasons the person is giving for not coming back. Now, in the case of a woman who is pregnant, there are some mitigating circumstances in that one that would need to be taken into account, again, on a case-by-case basis, depending upon the state, depending upon maternity leave laws in that state, policy, past precedent, and so on. The wrinkle right now, again, and Kay, you alluded to it, is people who potentially are making more money on unemployment than they would be making by working in the practice. Here's the bottom line. Let's say, Kay, you're my employee. I have furloughed you or laid you off. You're now on unemployment. I come to you and I say, we are reopening on this day. This is the day that you are to be back at work and be reinstated. And you tell me no. At that point, I have an interactive conversation about the reason. If ultimately the only reason is unemployment, that's not reason enough for this employee to deny coming back to work. At that point, this person has been offered work. The person is capable of doing the work. Again, there's no conflicting, let's say, local or state mandates with that. And at that point, the person has to accept the work, or this employee runs the risk of losing all of their unemployment. So
then the doctor would then basically send something to the unemployment saying that they've offered them work and they refuse to come back?
yeah, and employees also have to report in for their employment to continue. They report into the UI agency every single week, and they're answering questions like, did you look for work? Were you offered work? How much was the work that you were offered, etc. And so either the employee is going to be truthful or not truthful, but somewhere along the line, yeah, it's going to catch up with them.
So, okay, and then let me just go, there's so many, let me just see what this one says. This was, do I still have to pay the employees another 10 weeks after 2 weeks unpaid? I will need to hire and train another front desk. We did this for her maternity. It was, so basically, you know, they have to make sure they use their PP money, and they have to hire, and, you know, what's the financial burden if they can't come back and they want to hire somebody and they have to have all that their PPP money used?
Well, relative to,
they can use that can they use that for a new employee?
oh, sure. PPP money can be used for anyone who is working for you. You do not have to bring back the exact same people. You just have to spend at least 75% on payroll within the guidelines of what is defined as payroll. And you have to have your staffing levels back up to 100%. It's not the exact same people. It's not even the exact same head count. It's the same number of what they call FTEs, or full-time equivalents. Now back to the question. I appreciate the challenge that exists with maternity leave and having a temporary employee while someone is out on maternity leave. A difference with FFCRA leave is that the employee is being paid, but you are being reimbursed for that. So there is not a financial strain or obligation in this one. I get it's still kind of a headache and so on, but it's not something that financially is going to necessarily hurt. Just because a person is afforded up to this 10 weeks of family leave, it doesn't mean they get the full 10 weeks. They get however much leave is appropriate for whatever the triggering reason was. So in family leave, it's childcare facilities being closed. Well, as soon as childcare facilities open, the leave stops because that reason that the person was on leave has ended.
Okay, and then another question, FFCRA, will that also apply to part-time employees?
Yes. Yeah, it's just at that point it's prorated. So it's based on a 40-hour week. So if someone works only 20 hours in a week, they get the equivalent of half of the amount of leave that would otherwise be given.
Okay, and then if an employee gets sick from COVID at work, does workman comp cover this?
Yes.
So as long as do they have to check anything on their policy, or is it automatically covered?
It's our understanding that all the policies cover that, but it would certainly benefit just checking to make sure.
And then another question is, what would be good to put in an employee manual to get it updated during this time? Is there like any certain things that you think should be updated?
Well, there needs to be an FFCRA policy that's actually incorporated into the manual. There is a specific leave request form that should be part of the personnel forms that you have. so that all that again is delineated and spelled out. Those two things at an absolute minimum.
Okay, and then another one says they thought the ADA gave the impression that the dentists were exempt from sick leave, and they'd given 3 specific reasons, and as long as they, I guess, were applied to one of those reasons, that they were exempt. Have you heard anything about that?
Again, it goes back to what I said earlier about exemption. A lot of misinformation out there. No exemption for small employers, no exemptions just blanket for dentists. Yes, there are 3 reasons. I think if you really read through what the 3 reasons are, it's going to be pretty hard to ever truly claim and be able to prove that those reasons really applied to you. For example, one of them is you can't live without this person. This person must work for you. But then someone's going to ask you, well, how long have they worked for you? And you're going to say, oh, they worked for me for the last 3 or 4 years. Has the person ever gone on vacation? And you're going to say, yeah. Has the person ever been sick and stayed at home? Yeah. And you worked and everything was fine. So you found ways to work around it. How in the world are you going to be able to claim somehow that in this situation, it's different? The other part is, I don't want to be the employer. Maybe some of you do. I don't want to be the employer who looks at the employee who I know, for all intents and purposes, kind of lives paycheck to paycheck. And I'm going to look at this person and say, sorry, I'm exempt. You have to work, or if you can't work, you don't get any money. I don't want to be the employer who says that, number one. And number two, I don't want to be the employer who tests that. Because the odds are, in what is now, in this situation, like it or not, an absolute employee-friendly situation, there's no way I'm going to prevail with that.
Okay, and then I think we have time for one more. There is others out there, but let me just say this, guys. Anything that we didn't get to on this webinar, Tim said he would make sure he answers, and we will be sending out the Q&A for Tim's part of the webinar to everyone who attended. So if I didn't get to all of your questions, Tim, thank you for taking the time to respond to everybody, because there's so many, and I want to make sure that we answer everyone. I think we have like over 32 questions. So the last one is, for this part of the webinar, is how many hours of sick leave is under this ACT?
80 hours. And again, that's prorated. So it's 80 hours for someone who works a 40-hour week. If someone works 3/4 of that, so they only work a 30-hour week, well, then they get 3/4 of 80 hours. So it's prorated.
So I think I have one more. This one's kind of important. It says, what liability do we take if someone gets COVID from my office?
The only liability you have in that case, which this is a great question to lead into Linda and Leslie's presentation, the only liability that you have is if you have not followed the protocols that have been established by the CDC and OSHA. And you've either cut corners or you haven't really ensured that you have the PPEs that you really need, and so on. Then there's absolute liability for that. We've gotten questions from people who have said, well, can I get my employees to sign some kind of a waiver of liability? Well, in the whole HR world, there's this line that says employees cannot waive their rights under the law. And the laws specifically state if an employee is working and it is unsafe because protocols and procedures are not being followed, then no amount of waiver form that has been signed by an employee is going to help at all. So the liability relates to just making sure you're covering the T's and crossing the I's, or crossing T's and dotting the I's relative to all the CDC and OSHA guidelines and requirements.
So, okay, with that being said, I want to say this. So I'm glad this slide is still up. So guys, if you don't have an HR manual, You know, I will say that please make sure, even if you don't get Tim's, make sure that you get one. And that's really for both sides, right, Tim? That's for the employer and the employee. It's really and truly what I call great communication, because if it's not written down, you can't say you agreed to anything. Would you say that same thing, Tim?
Totally and completely. Yep.
So guys, this is Tim's website. He's willing to answer questions. He'll look at the one you have now. We just really want to make sure that we can help you get started right away and get started back on the right foot. So thank you so much. So please, guys, this is his email. Take a picture of this slide. And then, Tim, you're going to also be sending us a little handout to give to everybody. Is that a checklist?
Correct.
So at the end of the webinar, besides sending the questions and answers, we'll also send a little checklist of everything you went over. So thank you for all of that, Tim. And you do this all on your own time, so I can't say thank you enough. And so with that being said, what I would like to do is go ahead and switch out the PowerPoints. And while that's happening, I hear that my amazing boss is back on. There he is. Hey, Chuck.
Yeah, sorry about that. We had a little internet snafu in our house. So thank you very much for giving me another chance. I apologize for before. But Kay, my favorite part is getting introduced. What I was saying before was, as we change the slide deck, is the thing that's most exciting to me about this presentation today is it's the first one in our building for the future. The last time we all got together, it was all about coping with crisis. And today it's about what do we do in the new normal? How do we navigate and how do we get back to business? So first of all, thank you to Kay and the practice development team at Benco, the practice solutions team, for putting this together. Second one is, Tim, thank you very much. You are truly one of the most professional speakers out there. I will give a little sales pitch, which is, I think the best $560 a year somebody can spend is to have you be their outsourced HR professional in dental office. I very much encourage everybody to outsource with Tim. He's terrific. And my pleasure. Thank you. And moving forward, we've got Linda Harvey and Leslie Canham, two of the experts on infection control. The infection control topic is changing so quickly these days, it's hard to even know what today's rules are versus yesterday. As of today, Linda and Leslie are the most informed folks in dentistry, and we are very excited to hear from them today. Thank you for introducing us to all of the infection control protocols and procedures for the new normal. Thank you, ladies.
Well, thank you for having us as well. We're happy to be here this afternoon. My name is Linda Harvey, and as we jump right into navigating the new normal in dentistry with COVID-19, Leslie and I are going to be sharing 4 different objectives and information in these 4 areas: preparing your patients to return, preparing your practice, preparing yourself, and then lastly, just, you know, how are we going to be able to manage the aerosols and decontamination in our practices? So that's going to be very important. And I'm happy to say that Tim did a fabulous job as always, and several of the topics that Tim mentioned do cross over with items that Leslie and I'll be speaking about. So I'm going to address the first 2 topics, and just to please know that everything that Leslie and I talk about today, our content is relative as of today. You know, almost every day we wake up and there's some change. Hopefully the change is now the numbers are going decreasing side as far as new cases of COVID, but we could wake up tomorrow and there could be new changes with the CDC. So this is what's relevant today for you all. The first thing I'd like to talk about as we begin to return with the new normal are some things that Tim did mention, but let's go a little bit deeper. First is instilling confidence in your patients about coming back. You know, I like one of the things that, say, Revenue Well has done in the past, and their team motto from their website has been communicate early and communicate often. And from the risk management perspective, I think that's one of the first and foremost things to consider. If you have only sent out 1 or 2 messages to your patients this entire time that, hey, we're closed, or hey, call us if you have an emergency, that will not be enough times of having contact with those patients to help them feel confident about coming back to your practice. We want them to realize that you've made some changes as well. After all, every time we make one of those quick runs to the grocery store or to the pharmacy, we're experiencing that as consumers, aren't we? So they're going to be looking to see what their new experience is going to be in your practice as well. So be sure that you are leveraging technology. Tim touched on that a little bit. If you can get the forms out to the patients in advance, especially with the pre-screening information that we'll talk about in just a minute, that's going to lessen the load for your team members, and it will lessen the time that the patients will have to be sitting in the reception area and just kind of keep things moving in that new flow that we'll talk about shortly. Let's take a couple minutes and talk about the pre-screening process. No doubt when you've been seeing your emergency patients, you've been following the CDC guidelines for the types of questions to ask your patients. So please know that that's going to be ongoing for the foreseeable future because we really don't know how long we're going to be needing to screen for COVID-19. And actually, once we start the screening process, to me, it's going to make perfect sense that why don't we just keep it incorporated in our workflow practice as we go forward anyway. Start part of that medical history before the patient comes in. How many times have you had a patient sit in your chair and they say, I just have a little fever blister, or I have a little cold, but you're going to be okay because you're wearing a mask and glasses. In the meantime, they've been all throughout their office sharing their germs everywhere. So the questions that I'd like you to consider when it comes to screening your patients prior to a visit are 4 categories. Symptoms and contact are the first 2. Has the patient or anyone in their household had a fever or any respiratory symptoms in the last 14 days? Just recently, the CDC expanded the number of types of symptoms, so be sure you're looking at these other symptoms as well, as far as fatigue, sore throat, headache, muscle pain, those types of things. Very important to keep those in mind, not just for when you're pre-screening your patients, but when we talk about temperatures for the staff as well. Second, check to see if the patient or anyone in their household has had close contact with anybody that's been known or suspected to have COVID-19. Let's face it, if you have patients or members of their household that work in high-risk areas, then they may be more apt to be exposed to suspected cases of COVID if they or their spouse or their partner works in a hospital, a medical center, or they're a first responder. Additional questions to think about here are with medications. So, let's start with travel. Third category, travel. Has the patient or anyone in their household been in any area of ongoing spread of COVID-19 in the last 14 days? You know, initially before international travel really kind of came to a screeching halt, that's what we were asking our patients. Have you recently been to China or any place in Europe? But now we're looking at areas such that where's the patient taken any other trips? Bus, train, plane, or long car rides? Where have they been in the past 14 days, or anyone in their household? Well, the fourth category here is medications. Doctors and team members, you're used to updating the medical history on a regular basis, right? Every appointment. Well, now before the patient comes in, begin asking about any medications that they've taken that may have lowered their temperature. That would be important for you as you're making a judgment on when you're taking that patient's temperature, is it really an accurate temperature or not? So let's talk about taking patient temperatures for a couple of minutes. When I started researching this, you know, we're all Dr. Moms, Dr. Dads, or we've taken our own temperature in the past, and so we have some knowledge of taking temperatures, right? But you know, there's a few more medical points to keep in mind with this. And one is the fact that, yes, we know that everyone's baseline temperature should be 98.6, but you know, that's not necessarily the case. And we're looking at, as Tim mentioned, any fever that's at or above 100.4 degrees. But as we mentioned, fevers can be impacted by taking certain medications. And depending on what part of the country you live in, if the patient's been sitting in the car waiting for your call or your text to come on in, if it's hot or cold in that car, that's going to impact their body temperature as well. And not everyone's temperature starts out at 98.6. So in looking at what type of thermometer to use, please avoid using the forehead strips, that just little strips that go across the top. That may seem like an easy strategy for patients or team members. However, that strip only measures the skin temperature and it's not measuring the body temperature. Likewise with the oral mercury thermometer. That's a hazardous waste in that thermometer, and if it should break, then we have an issue there with hazardous waste. And so everyone is leveraging and working towards the non-contact thermometers, tympanic or infrared. So either one of those are fine. In our research, we're coming up and finding that the good brand thermometers are FDA cleared, so you can put your trust in those. But please bear in mind something else about temperatures. When you take a tympanic temperature, that can be 1/2 to 1 full degree lower, pardon me, higher than our baseline body temperature, higher than. While infrared temperatures that can allow you to do the temporal forehead area or the front of the forehead, those temperatures tend to be 1/2 to a full degree lower than our baseline temperature. So depending on if the patient has taken any medications and if the patient, what technique you're using, that can all have implications with the temperature that the patient is presenting with. So it just bears to mind that asking those good questions about who they've been in contact with, what symptoms they have, and you know, have they had any travel, are very key to helping to put the pieces of the puzzle together when you're screening your patients. Let's talk a little bit about screening our patients post-treatment. This is also a recommendation that came out originally on April 4th from the Center for Disease Control. So what we're recommending here, as Tim had mentioned, that these symptoms can manifest themselves anywhere between 2 and 14 days after someone has been exposed to the COVID virus. And during those first 2 days, you are contagious, but you're asymptomatic. So that is a problem for both possibly patients presenting that could be COVID positive, as well as your team members when they return to work. So please institute a policy where you're contacting all your patients 48 hours after their visit to determine have they had any COVID symptoms that have developed. While this may seem like a little bit of a challenge at first, if we come back with slower schedules, you'll have a chance to develop a workflow that won't take a lot of interruption. And why not leverage the technology from your patient communication platforms, a text or an email to the patient. You could also include the symptoms again with COVID and find out if they've showed any of those symptoms, then you'll know what to do next. By all means, please be sure you're documenting the pre-screening questions and patient's temperature in your demo records as well. That's an important piece of the medical chart, right? Let's talk about now instilling confidence in your team members. This is extremely important. So if you have only been in front of your team members just a couple of times, how are you doing? Or I got my PPP loan, or I'm waiting for money, then you probably won't be able to bring them back with a lot of confidence. They need to know what safeguards you're putting in place for them. Check-in, check-out process, spacing in the reception area. How about the common areas, restroom, break room? What's your plan going to be for that? Are you going to be able to stagger lunch hours, have a lighter schedule, for example? But the biggest point here that I like to make from this slide is the very last bullet. And that is, please prepare your teams to be answering questions that patients may have about infection control and your protocols. We want them to be comfortable. We don't want that nervous, giggly laugh because someone doesn't know the answer and they're embarrassed. We want your team to step up to the plate and be confident answering those questions. So please work on that as part of your dress rehearsal. So let's talk about some interim guidelines related to staff wellness. We talked, and Tim mentioned already, screening your healthcare workers before they come to work. And as Tim mentioned and reminded us, that needs to be on the clock, absolutely. So you're asking for the same symptoms and signs with your patients. And I believe in the ADA toolkit recently that came out, there's a great log you can use for maintaining staff temperatures, which would be a great place to have it in one location. Tim, I can't remember if you mentioned for sure, but we would recommend that you have a medical illness policy. This may be a little different from your sick leave policy. So this probably won't fall into your HR manual, but more than likely it's going to fall into your infection control policies and procedures. Because this type of policy is, when are you going to send somebody home when they're sick? When are you going to allow them to come back when there's no symptoms or a doctor's note? So those two policies will go hand in hand, but this one may have a little bit different focus for you. Let's talk about some new areas here of just patients, team members that have potential exposure. So we're asking our team members to self-monitor for 14 days. But the important thing at the bottom is that if someone is wearing all the recommended PPE, the Center for Disease Control tells us that there's no work restrictions if they're asymptomatic. But let's talk about some information about what happens if they were symptomatic or had COVID. This information is relevant here that was updated, I think it was April 13th or 14th with the CDC, and it's the most current piece. But this strategy talks about what do you do in allowing a team member come back to work when they've had a confirmed case or there's been suspected COVID. So one strategy is the test-based method. In other words, when their temperature has been down for so many days without taking medication, the symptoms are resolving, then they go get a test from an FDA authorized use test to be sure that they are negative, and that's a requirement. So those are the two sections here with that. One of them is the tests have to be 24 hours apart, and the medical professionals will be aware of how to administer that for your team member and be sure that it's done appropriately. So once those 3 criteria are met, then somebody can come back to work. The other avenue is if you're not relying on a test-based strategy or it can't be used for some reason, then you can have at least some other symptoms here to monitor. That the employee has had at least 3 days or 72 hours have passed since they've recovered and all the symptoms, fever, everything have resolved without taking any medications. And then at least 7 days have passed since the first symptoms appeared. So that's one different technique. So whether you send the employee to be tested or whether you're going by symptoms, it's important that we know that we can bring that person back to work when they are healthy and well and not too soon. Because one of the last things we want to have happen is for your team members to bring COVID into your practice. And then after we've worked so hard to come back on, do everything just right, then you find yourself having to possibly close again for 2 weeks. Everyone has to self-isolate. So just to talk about some go live pieces from your patient and employee perspective, looking at scheduling. I think Tim alluded to some of this and mentioned a few points. So how are you going to manage that? And being sure that you put in the 48-hour post-care follow-up. Where are your patients going to wait? Are you going to keep them all in the car where they come in straight from the car, go to the operatory? Or will you allow certain, move some of the reception area seats around and have just limited space for folks to sit? Taking temperatures, I mentioned documenting that in the patient record. And just what other visual changes will the patient see when they come in? I know a lot of offices are choosing to put up some type of plexiglass at the front. Please know that is not mandatory, but it's one of those suggestions that might be a good thing to implement to help your team feel more comfortable. So I would recommend having that collaborative conversation with your team to be sure that all those types of areas are addressed and you know how the patients are going to flow through the practice. The last thing I'd like to discuss is just developing a go-live plan from the team perspective. Tim did a great job of covering, how to address daycare issues for staff. What PPE are you going to provide for your office team in the front? Do they need some masks? Yes. Do they need some gloves? Possibly so. Plexiglass is another option that we mentioned. And then be in tune to any confidential health concerns that team members may have that maybe they haven't shared with you, or perhaps the health concern of one of their members of their household. I know someone here in the Florida area, an older individual, over 60, her husband's awaiting a transplant. So she's somebody that their office is going to set her up to work from home, so she doesn't have to come in and be around anybody else. That was a great option for that scenario. Staggering schedules, lunch hours, all those types of things. And then be sure that you do simulate the care flow. And I like the analogy, I think if I get this right, as football fans, right? It's the game day analogy, right? And so with the lesser patients that you're seeing, you do some practice sessions. And so then the first day or two, if something isn't flowing right, now you have time in your schedule to make sure that you can adjust that flow and move steadily and just keep scaling back up little by little. So again, document all that information in the patient record. Oh, excuse me, document your additional PPE in the patient record. That's extremely important. So at this point, I'd like to turn over the program to my colleague, Leslie Canham, and she will go through the next couple of points on the slides.
And I'm going to go ahead and unmute myself. So Linda talked a lot about preparing, making sure that your practice is ready. And Tim talked a lot about that. And I want to focus on you, preparing yourself. So we now have a new world that we are in. Let me see if I can advance my slides. There we go. And OSHA actually jumped up to the plate pretty quickly with a new guidance for workplaces. And this was actually published in 2020 in April. And they have the hierarchy of the risk of occupational settings for individuals in workplaces. And dental healthcare workers have been placed at the very top of the pyramid. So we are considered to be very high risk exposure for COVID-19. Now, in the past, or yesterday when we were open in our practices, we had standard precautions and we adhered to hand hygiene and PPE and of course, mask and eye protection. We have introduced cough etiquette that became very popular when we had swine flu in 2009. And of course, all of the other bloodborne pathogen issues such as sharp safety and safe injection practices for our patients, sterile instruments and devices, and of course, cleaning and disinfecting environmental surfaces. But now we have COVID-19 on the block. And so we have airborne precautions that we need to be aware of. Primarily, hospitals were the ones that the workers at hospitals had to be aware of airborne precautions because they would have patients that would come to their facility who had highly transmissible diseases. For example, TB. So when someone has TB, the airborne precautions come in place and a patient who's in the hospital is placed in a special room called an airborne infection isolation room. And every healthcare worker who enters that room will see a sign in front of the door that reminds them to stop and clean their hands. And that's before they enter the room, and of course when they leave, to put on a fit-tested N95 or higher level respirator before entering the room, remove the respirator after exiting the room and closing the door, and then the door must remain closed so that that patient's airborne pathogen does not circulate around the other facility or to circulate out to other people. So now with this airborne pathogen that we have to be aware of, we want to make sure that we have the right PPE. Now, it starts with hand hygiene. And of course, everyone knows about washing their hands. I don't want to go there because that's remedial for you. And you don't need to have information that you already have. However, I want you to know that your patients have this information now, and they're more aware of hand hygiene than ever before. So we want to make sure that they see you wash your hands. And if you use alcohol hand sanitizer, that they see you use that as well. If they're unable to see you wash your hands, maybe your sink is behind their head or out of their line of sight, or the alcohol dispenser is where they can't see it, make a show of drying your hands or rubbing in the alcohol hand sanitizer when you come back, because they have a very big education now on what we're supposed to be doing, and they want to be safe in our care as well. Now, when it comes to you, personal protective attire, we clinically usually have a clinical jacket and of course our gloves. And now we're looking at, with aerosol procedures, N95 respirators or KN95 respirators, surgical face mask, and a face shield. I've been monitoring some of the questions as they came in, and someone asked whether a face shield is required. And actually, after the question said, well, they should be. And actually, I know there's been some advocacy for requiring face shields. So I believe we will be seeing some changes, because a face shield certainly does provide an extra layer of protection from droplets and aerosols that we might be exposed to. It's not full protection, but it's an extra layer. And everything really counts right now. We may be seeing some changes to what kind of PPE we're going to employ in our practices. And the recommendation now is, because we're unfamiliar with exactly what kind of territory with infectious disease management we're going to be entering in our treatment room, is my recommendation to have a disposable clinical jacket that can be changed and disposed of after each patient. So this picture here shows either an N95 or higher respirator, a face shield, or goggles. And you might remember wearing goggles when you were in school or in your biology class or your chemistry class, where the goggles actually protected your eyes. Your mucous membranes are the I guess you could say the receptor for COVID-19. So that's why you're hearing a lot about don't touch your eyes, nose, or mouth, because if the virus does contact those surfaces, that's a beautiful portal of entry to your body. The N95 respirator protects your nose and your mouth, and hopefully you're going to be wearing a face shield, or better, maybe goggles to protect your eyes. And of course, we've always worn our gloves just like we did in the past. Speaking of your gloves, we want to make sure that your gloves fit well and that you check for tears and holes, and recognize that gloves don't provide you 100% protection, because sometimes they have micro perforations or pinholes. And so we want to make certain that not only are we checking our gloves when we don them, I always like to hold up my hands and check for tears and holes. And the other thing to do is, when you remove your gloves, make sure that you remove them properly. There are plenty of videos on the CDC website and on YouTube on how to properly remove your exam gloves. And bear in mind that sometimes, even if you properly remove your gloves, sometimes what's on the outside of the glove can splash back on your skin. So hand hygiene is always a must afterwards. Another thing to keep in mind is that we may find that it's difficult to get all the right PPE. And so we're looking at working with what's called crisis strategies. And at this time during a pandemic, some of the regulations are a little bit relaxed because we're in a crisis mode and we need to be able to wear something. So someone asked about reuse of PPE. There's what's called extended use of face masks, and I actually have the CDC website up in front of me right now. This is something that you can bring up on your own. Just go to cdc.gov, click on COVID-19, look for the section for healthcare providers, and there's a great section for dental professionals, which I'll show you about. I was being asked a few months ago when we first started to notice that our PPE supplies were going to China, whether we could wash our masks. And I actually found something kind of cute on Facebook. Jennifer Yoon from Hugh Freedy had posted this, and the answer is no, you cannot wash and sterilize your surgical face mask. Please don't do this. This is actually going to weaken the mask. So moisture will weaken the fibers, and the heat from the sterilizer may have an effect on the elastic that holds the mask firmly to your face. So make sure that you have adequate supplies to see patients. And if you don't have adequate supplies to see your patients, then at that point, it looks like you may have to refer those patients to a facility where they can be seen. CDC guidelines still stand. Always practice standard precautions and make sure you change your mask and gloves after every patient. Don't wash your mask and gloves for reuse. Now, at this time, NIOSH approves the use of non-medical N95 respirators, as well as other, I guess you could say, respirators that have not been cleared by FDA that are from other countries, again, because we're in this crisis capacity. But that's only for a limited time. And once that limited time, I believe it's the utilization of use time or of PPE time expires, then we're going to not be able to use masks like, for example, N95s that come from other countries that have not been cleared. So we'll be back to having to use the masks that are cleared. Remember again that what we're doing now is what's considered to be crisis capacity. Other questions that seem to come up are what they call limited reuse of the mask as well. And again, I'm on that CDC website that covers what you would do for either contingency capacity or crisis capacity. And limited reuse of face masks is the practice of using the same face mask by one healthcare provider for multiple encounters with patients, but removing it after each encounter. And it's actually unknown what the potential chance of contact transmission to you is. If you touch a contaminated mask with your hands or you touch your face afterwards, then there's a good chance that you could transmit whatever's on that mask to you. And what I'm speaking of is the N95s. Now, just to give you an idea of the size of the type of aerosols that we're exposed to, and aerosols, again, travel further than droplets do. So aerosols sometimes can remain suspended in the air for long periods of time. 95% of all dental aerosols are 5 microns or less in diameter and can't be seen. So particles in the air are measured in micrometers. 1 micrometer is about 1/millionth of a meter, or 1/25,400th of an inch. That's hard to say. To give you an idea of how small a micrometer sized particle is, waste matter from a dust mite is about 5 micrometers in size, while a strand of hair is about 50 to 150 micrometers wide. Now, this next slide is not to scale. It's the best I could do with the PowerPoint. But to give you an idea of the diameter of a coronavirus, it's 60 to 140 nanometers. Now, a nanometer is 1/1000th of a micrometer. So if that little teeny tiny green dot that you see in the corner with the arrow pointing at it, if that was a nanometer, then again, not to scale, a micrometer is much larger. You could put 1,000 of those little dots inside that micrometer. The levels of mask protection that we're using today are actually rated by what's called the American Society for Testing and Materials Standard. So the box of masks that you use for medical should have that ASTM rating as a level 1, 2, or 3. With level 1 really being the least protective, it's only for low aerosols. So if you're the person that does exams, radiographs, and impressions all day, then this would be an ideal mask for you at 98% bacterial filtration efficiency and particulate filtration efficiency. A level 2 mask is really much better. It comes up at moderate protection with 98% bacterial filtration efficiency and particulate filtration efficiency. So this is for restorative, as you're using a handpiece, you're cooling the burr with the water spray, limited oral surgery, hand instrumentation, and prophy. Moderate aerosols in these particular cases. A level 3 mask, boy, did I get a lot of questions about level 3 masks before coronavirus was around. And over the last couple of years, I had many hygienists asking me for documentation that they could give to their employers about level 3 masks being better and higher protection. And while the bacterial filtration efficiency is the same as a level 2, 98%, it's more moisture resistant. And so when complex oral surgery, crown preps, use of ultrasonic scalers or lasers, that's where we have high aerosols, and level 3 mask is more fluid resistant. A little bit harder to breathe through, but more fluid resistant. Now the N95 respirator, here's where we get into probably the biggest bucket of questions that we'll have during this crisis is, number one, what if I can't get N95 respirators? Well, realize at that point, if you're performing an aerosolized type of procedure, you are at great risk for exposure to a patient who may be COVID-19 positive. And so if you are wearing an N95 respirator and you have all the other types of protection in place, your personal protective equipment, making sure you're performing hand hygiene after caring for the patient and removing PPE, not touching your eyes, nose, and mouth, you're better protected. But if you can't find N95 respirators, then my recommendation is that you're not doing anything that is an aerosolized generating procedure. So if you are going to use an N95 respirator at work, then there are some OSHA requirements that are connected with that. And one is a fit test requirement, which is an initial fit test and then an annual fit test. And then secondly, the wearer must have a medical evaluation and be cleared to be physically fit enough to wear an N95 respirator. Someone asked a question about an assistant that really felt stifled. And this wasn't on this program, it was on a program I was on a little earlier today, my own webinar. And she said her assistant got, I guess, dizzy wearing the N95 respirator. Well, this is a person that has difficulty breathing through something that is more heavily, more tightly woven. The way that I like to describe how I feel when I'm wearing an N95 respirator, if I get into bed and put the blanket and the covers and the bedspread over my face, I can't breathe very well. And it doesn't take long for me to throw those covers off my face so I can breathe. That's kind of how I feel, maybe confined in an N95 respirator. Now, Linda actually has some comments to make about N95 respirators and some further requirements surrounding written plans. Linda?
Oh, thank you, Leslie. I think there's been some confusion. This is an OSHA standard, this respiratory protection standard. It's been in existence since I think probably the 90s and updated periodically by OSHA. So we are required to follow that respiratory standard as well, meaning that we need to have a respiratory protection plan in place. The medical evaluation that Leslie talked about has to be conducted by a licensed healthcare provider, a physician, or other similar allied health professional licensed. Unfortunately, doctors, that's not us in dentistry. And that, because the fit test, as Leslie said, the medical evaluation will tell you or tell the employee whether they can actually wear a fitted mask like an N95 or a KN95 mask. Because at that point, if they have health concerns, that will be drawn out by that medical professional. And then the next step is to have some kind of training for your team members. How do they know when to don and doff it? How do they make sure they're breathing properly? Because the third step, which is called a fit test, has to be conducted by someone who's had commensurate of training or experience in this area, like occupational health nurse. My team and I, we're getting trained in this so we can learn how to do it. And you have to have special equipment to do the fit test. The fit test determines that the employee is wearing the right make, model, and size of an N95 or KN95 mask. And for the most part, we've been just focusing on, can you even find that PPE anywhere? And most of the time it's been, no, it's been very scarce. So much less having 2 or 3 makes and models and sizes for someone to try it. You're going to be lucky if we have one, right? But nevertheless, we have to be sure that's perfectly sealed and it's fits that person properly. And then the seal check is something that's different than a fit test. The seal check is something that you and your team members, doctors, will all check each time you don the mask to make sure that the seal is properly fitting around your nose, cheeks, and your chin. So as Leslie described, I really liked her analogy. The analogy that I've been using is, I live in Florida, so I'm at sea level. And then I go to Denver, and then I go to Breckenridge, and then I go up to Leadville. And I'm hitting between 9,000 and 11,000 feet above sea level. And each step along the way, my heart and lungs have to work harder. So we'll take some time to adjust to these masks. Thank you, Leslie.
Well, thank you, Linda. And by the way, I was looking at some of the questions. I know we're going to try to get to the questions, as many as we can during the webinar, but we will at a point here come to a breaking spot where we can start to address those questions. There's several great documents that you can download. One from the CDC website on understanding the difference between a surgical face mask and an N95 respirator. And so I encourage you to go to CDC's website and take a look there so that you can download this document and get more familiar. If you're going to go back to practice and wear an N95 respirator, then you really should know more about it and have the training, as Linda mentioned. And then there's also on the ADA website, Interim Mask and Face Shield Guidelines. So you can take a look at that document as well. And I believe that that'll answer a lot of your questions. So rather than take the time here, I'll give you the resources and you can get that yourself. Now, let's say that you can't find the N95 respirators or any type of similar medical device. I know that we now have temporary approval of using the construction type of devices. So a filtering face pit respirator, FFR, an elastrometric half face face piece respirator, and the full face piece respirator. And then there's also another type of respirator, but there's a different type of fit test that has to take place with that one, with the powered air purifying respirator. And so you can see that at the bottom of the screen. It almost seems like we're in an astronaut suit to come and see our patients now. Well, what we can do with the supplies that hopefully we will have back within our hands again, a face shield. And this is a picture of a disposable face shield. This is my preference because it's very light and easy to wear. And then there's also the more hard plastic face shield. And this is one, they call it Opti-Op, where it's a hard plastic visor, sort of like a tennis visor you would wear on your head with a hard plastic face shield. And both of these can be disinfected between patients. So this is something that's an option, but because face shields are found to be in short supply, and also because face shields sometimes don't accommodate the loops that many of our healthcare providers wear, there are other face shields that are now being manufactured by all sorts of different industries that will help to accommodate. I actually saw on the news last night where a pediatrician had created her own type of face shield that was fitted and printed on a machine, and it looked like she had her hair in sort of an octagon, or her whole face in an octagon fishbowl, but it actually seemed a lot more user-friendly to maybe pediatric patients. Now remember, when you wear a face shield, you are not dismissed from wearing a surgical face mask or N95 respirator if you are able to get them. It was Linda that advised me just the other day that the CDC website had changed and updated their guidance for dental settings on April 27th. So the last time, I think it was April 7th. We are seeing changes on the ADA website, on the CDC website. Look for changes on OSHA's website, and those changes are coming in rapid fire. So I recommend that if you are going to use some of those resources that we mentioned, that you check back with all of them. And I think one of the pieces of this material or this webinar, I have a page that is a PDF of all the links to these different resources that I'm mentioning today. And you'll be able to access them just by clicking on the link of the PDF. All of the links are good as of this morning, even though there's changes. Now, the next section that I know there's a lot of questions about is managing aerosols and then decontamination or disinfection. So now we are looking at a different type of transmission-based precautions than we were in the past. We were looking, we contact precautions, but droplet precautions, we sometimes have droplets and they're heavier and they fall out more easily on the ground. But now Airborne Precautions. These are aerosols that are generated that we've had already been acquainted with in our dental practices, but our airborne pathogens remain suspended in the air for long periods of time. So, for example, one of the links that I'm providing you on my handout is a PDF that takes you to the National Institute of Health, where on March 17th, they documented that the scientists found that COVID was detectable in aerosols for up to 3 hours. So if you worked on a patient, used an ultrasonic scaler or used a handpiece, you know, in your crown prep, that those aerosols can remain suspended in your treatment room for longer than your appointment with the patient. So that does create kind of a conundrum. How do we reduce the risk, and how do we make sure that that room is safe to enter again? It would be about the same as if you had a patient who had active infectious TB. Now, fortunately, in the United States, we have some pretty good immunity against TB, and we don't have very many cases. Same thing with measles. Measles can remain suspended in the air for like 2 hours at a time. Again, we have wonderful herd immunity in the United States, and there are really very few individuals who are not already vaccinated from the rubeola virus. So, today, we have, I think there are certain religious communities that don't vaccinate, and then there's certain individuals that choose for whatever reason to not vaccinate their children. People who are not vaccinated have something like a 97% chance of acquiring the measles, which is highly infectious, highly transmissible if they're exposed to it. However, if you are vaccinated for measles, then you have a very good guarantee that you're not going to get the virus. Now, an interesting thing that was brought to my attention, just actually published in April as well, in JAMA, the Journal of American Medical Association. This is a picture of a sneeze, and they show a turbulent gas cloud from a human sneeze. So what has been discovered is that a sneeze can send droplets from a patient 23 to 27 feet. So if we have a patient who's COVID positive and they sneeze, that means that 6 feet social distancing isn't quite enough. In the earlier report I mentioned, there was also evidence that we may be looking at 12 feet, 12 to 16 feet for people to be out, not necessarily in our dental practices, but out among the community. They're not only coughing and sneezing, but also talking and breathing can aerosolize the coronavirus. So what do we do about that? How do we manage? What are our engineering controls to manage aerosols? Well, bringing back use of rubber dam, that's going to help reduce aerosols. Using disposable or autoclavable nitrous masks and tubing. Skilled use of high velocity evacuation. So again, that's going to suck up a lot of those aerosols right at the point of contact. And then of course, regular maintenance of your evacuation lines daily with the solution, or more frequently if you perform surgery, and also of your vacuum pump. I actually attended a webinar that was almost an hour long simply on evacuation. And I signed up for that webinar because I was really curious to know how anybody could talk for an hour about evacuation lines. But I was surprised that, again, there's so much to know about maintaining your equipment, keeping it in good shape, and having equipment replaced when it starts to wear out. So that's where it's going to be really important to make sure that your suction is suctioning as well as it can be. There are other areas that we have less information about that we might want to explore when it comes to coronavirus. And that includes chairside aerosol extraction systems. That's a system that is like a unit that sits next to your patient's chair that has an evacuation system, and there's a hood that comes out, looks like a dryer vent, like the back of my dryer, my clothes dryer, and a bell-shaped type of vent that would go over the patient's mouth to bring in the aerosols that get missed by the other systems that you have of a high velocity evacuator. There's air scrubbers and portable HEPA filter units. There are treatment rooms that can have air exchanges for the treatment room, and that's an engineering type of situation where you would have to make sure that your treatment room could accommodate that, and that the air exchanges are, I think it's 12 per hour. There's been a lot of talk about UV light and how that might work in a treatment room. And then there are what we have in the hospitals, which are called airborne infection isolation rooms. And these rooms are maintained under negative pressure to the adjacent areas so that the air air contaminated with infectious particles or droplet nuclei does not escape the room. Our dental practices are not airborne infection isolation rooms. In fact, many dental practices, like pediatric and orthodontic, are open bay style. So we have some additional roadblocks and conundrums to reach over. Again, with the aerosols, there's a lot of information that will be coming at you as we get closer to reopening our practices, and I recommend that you do your due diligence to make sure that whatever you're investing in is actually something that has been validated to work under the circumstances. Because I don't think we're going to turn our treatment rooms into hospital airborne infection isolation rooms. Now, again, moving toward recovery, when we find that we have control of this virus and it becomes something that's in our rear view mirror, like measles or like TB, but we still need to focus on disinfection, on surface disinfection. And one thing I want to mention there again is that our patients are acutely aware of what they're supposed to do for disinfection, which means that they're acutely aware of what we're supposed to be doing for disinfection. In fact, they've been told how to disinfect their purchases when they go to the market and bring home groceries, and to leave their cardboard boxes or cereal boxes outside for 24 hours, because they've been told that the virus can live on cardboard for that long a period of time. The study that I mentioned from National Institute of Health reports that a coronavirus can remain viable on surfaces for up to 3 hours, or 4 hours on copper, and 24 hours on cardboard, up to 2 to 3 days on plastic and stainless steel. So we really do need to make sure that we do our due diligence as well on surface disinfection, and we don't overdo, because one thing that we could have happen is that we get exposed to chemicals. We don't want to be drinking Clorox bleach, and we don't want to be using chemicals in excess to where we have health issues. There's this guidance that was issued that says that the U.S. poison centers their calls about disinfectant exposure increased by 20% from January 1st to March 31st. So we want to be very careful and understand that spraying Lysol disinfectant in the air is not going to manage your aerosols. In fact, doing too much of that is going to make it very hard to breathe, and it doesn't smell very good. In fact, I was in an office where they used a lot of aerosol, Lysol, thinking that, it was a good disinfectant for the air. Well, it does take care of odors, but, after a while, you can sort of taste it in the back of your throat and in your nose. So you don't want to get sick or get problems, other health issues, asthma or other respiratory issues from using disinfectants improperly. If you're wondering whether your disinfectant is something that is effective against COVID-2, then what you want, or COVID-19, you want to make sure that that you check the list on the EPA website. Again, that link is provided for you on that handout I have for you. This list was updated again recently on the 23rd of April, and EPA has actually made it easier for companies to get their products listed. They've kind of cut through some of the loopholes that they had to jump through and make sure that the public could get information about whether a product was effective against coronavirus. And remember, coronavirus was really only identified in November. So manufacturers had their products out long before November. Now, I just want to point out a very quick chart to you. This is the chart that is in the CDC Guidelines for Infection Control in Dental Settings from 2003. And it lists the strength of a disinfectant and the decreasing order of resistance of microorganisms to a germicidal disinfectant. And you see at the top of the list is bacterial spores. And that really requires sterilization, or if something is not heat resistant, cold sterile, so a liquid chemical sterilant like glutaraldehyde. Then we go down the list, we have mycobacteria, which is now at what's called an EPA registered hospital grade disinfectant with a tuberculocidal kill claim. Almost all of the disinfectants that I find in the dental offices I visit are intermediate level with it says tuberculocidal kill claim on the bottle. And then it goes down the list to non-lipid or small viruses, then fungi, and then it goes to vegetative bacteria. And you see that now EPA hospital disinfectants, where you can use a low-level disinfectant. So our benchmark organisms really are Staph aureus and Salmonella choleraceus and Pseudomonas aeruginosa. Those are all listed there. Coronavirus is a lipid virus, and you can see under lipid viruses, human immunodeficiency virus. herpes simplex virus, hepatitis B, hepatitis C. And looky here, who's at the bottom of the list, the easiest to kill? It's coronavirus. Now, this coronavirus is actually referring to the coronavirus that we were acquainted with in 2003 or 2002 when we had the SARS coronavirus. So the coronavirus that we're acquainted with now, which is one of the 7 strains of coronavirus that is out there, is one that is easily destructed. So you can kind of rest assured that what you're using is likely to take care of coronavirus in your dental office and as well as your home. In fact, when I looked at that list of approved disinfectants, I found even toilet bowl cleaner and many of the household products that I have in my laundry room or underneath my kitchen sink for cleaning the kitchen are effective against human coronavirus. The next step is to make sure that you're using your product properly. And I have no particular favorite disinfectant. I just happen to like this particular picture of cabbie wipes where they show that they're taking the wipe out of the container and you're cleaning your surface first. And then you throw away that wipe and you're just working with one surface. And then you go to the next wipe and you pull it out of the container and now you disinfect your surface. That's very important, not only to clean your surface with that disinfectant, because cleaning is very important, and using the disinfecting wipe is making sure that you're not exposing yourself while you're cleaning to those harmful pathogens that may be present. But also, you have to have a pre-clean surface in order for that disinfectant to actually do its job. It's no good if you take one wipe and you just wipe the surface and then you've maybe moved any debris out of the way and the organisms are like, oh boy, I'm happy because now I don't have gunk on top of me and I can proliferate and then I can transfer. I can get on your clothes or on your skin or on the patient's purse and I can ride out of this office. So we want to make sure that we kill those organisms. And you want to make sure you're using an EPA registered disinfectant. Many of the products that we use today meet that capacity and requirement. The more important part about using a disinfectant properly is making sure that you leave it wet on the surface long enough to do its job. So read the instructions. I happen to highlight this particular container because it shows instructions where it shows leave it visibly wet for 2 minutes. That's just for cleaning. If you look a little further, it says as a disinfectant, leave it visibly wet for 3 minutes. And there's those benchmark organisms, Staph aureus, Pseudomonas aeruginosa, and Salmonella. So make sure that you barrier protect the surfaces that are difficult to clean and disinfect, and that you do disinfect, of course, all those surfaces. Tim mentioned it at the beginning of the webinar, where even in your reception room, extend your infection control to all the surfaces. You want to prepare to get back to the business of providing safe dental care, and we want our patients to feel safe in our care. A wonderful resource, I call this my secret sauce, is OSAP, the Organization for Safety Asepsis and Prevention. Here is the OSAP website. You will find it also on my handout, my PDF, and look at the different links that they have. You can go to their website for free. They have opened it up to everyone, including non-members, and you can access every single link on their website that members pay for. And this particular link on COVID-19 takes you to all the CDC documents that I recommended, World Health Organization, OSHA, EPA, so you can check your disinfectants, ADA, so you can get all of that information on interim guidance, and of course, it has information from National Institute of Health. So you can see it's a great resource. We want our infection control to be on target because every single patient deserves a safe visit every single day, and we as dental workers deserve to be safe as well. I'm going to let Linda go ahead and see if she can grab some of those many questions that have come in while we have our contact information slide up.
Well, thank you, Leslie. That'll give you a chance to look and see what new ones have come in during your presentation. I'd like to address one question very quickly, one comment, and I was right on target. One doctor commented that, you know, we've been doing things so well in dentistry that now with all the additional PPE and precautions that we're taking, are we giving patients the wrong idea that we've been doing things less than appropriate in the past? Well, unfortunately, because SARS-CoV-2 is just, it's a global pandemic, not much is known about this virus and this illness. Everyone is taking precautions across the globe. So I think patients will be understanding, realizing that we didn't. The only adjunct that I would make to that, because it sounds like your office is doing a great job already, is that Leslie and I have been in many offices over the years where team members get slack. and doctors get slack, unfortunately. The one area that's hotly debated is the temperature. It's too hot to wear the jacket, and masks come down, they start being below the nose, or we don't have the proper eyewear on because these are not OSHA approved without side shields. So we have to just go back at this time, and this is a good time to go back and just review your former processes to make sure everything's on track. Briefly to address some documentation that I mentioned about both the PPE that you are wearing, the additional PPE, and the patient information. The pre-screening questions are part of the patient record, so I would definitely get that documented in the record, whether you're doing it through an electronic means, which is great because then you don't have the paper process to deal with. If you're relying on a paper process, then of course you're going to scan it and get into your electronic record as well. The part about documenting the additional PPE that you're wearing is that some of our insurance specialists in our industry are working with the ADA, and the ADA is working with some of the insurance companies to try to determine if we can seek some reimbursement for all this additional PPE. I understand the burden behind this, because I know now that even the N95 masks are selling for about $4 a piece during this crisis, which is difficult. So it definitely drives up the cost of PPE. So if there's a potential reimbursement in the future, then having the additional PPE documented in your dental record for that treatment would be ideal. Maybe you can make a couple of templates where you just drop in some auto notes, for example. And charging for that, I would go back and talk to your insurance companies, review your contracts so that you're not in violation of those contracts. But not being an insurance guru, I will defer that question to others. One question that I had was about the 7-day individuals who can come back to work 7 days post-illness and post-symptoms. That 7 days window is different time frame than the 2 to 14 days contracting the virus or knowing if you have the virus. So at that point, then the IgG antibodies have stepped in and the virus is subsided post 7 days post-illness, so it doesn't have to be the 14 days. The mandatory reporting to the health department if you have a COVID positive patient or staff member would depend on your state reporting guidelines. So I would check those first, talk to the health department and get some advice of what's required in your state or your province. And then also one thing that we should mention, Leslie, is that in many states, the CDC guidelines are written into your Dental Practice Act. So there aren't any, there's not any wiggle room. There's no more nice to know. It's all need to do, and we must follow. I'd like to talk about the fitness test and the medical clearance. OSHA only waived the annual fit testing. So when you look at the OSHA memorandum from both March and April, it was a second memorandum in April that clarified as well and just really pointed out the fact that the only thing OSHA has waived is the requirement for an annual fit test. We are working hard to find some resources where you can get you and your teams tested, doctors, online for reasonable fees. And I will make that information available to Kay as soon as we get that up and running, so that will help minimize your expense for that. Because that is both the initial fit test and the medical evaluation have to be conducted under federal law. Pre-screened 7 days illness, pediatric patients, let's talk about that real quick. So any of your practices, whether it's orthodontic, pediatric practice, or even a general practice where it's common practice, if you will, for patients who now drive, but they're minors, to bring themselves to their own appointments. So that presents another challenge with treating minors without the adults being present. And they are not able to give legal consent when it comes to updating those health history with those pre-screening questions. So I would analyze your workflow processes and determine how you can work with the parent or legal guardian to get that accomplished in advance.
Really quickly, Linda, can I just ask a little question? So I want everyone to make sure they take down this information. We're getting ready to do a change of the slides, and I definitely want to make sure they have your information before we take it away. So please make sure you write this down, take a picture of it. These two ladies are amazing when it comes to their knowledge of what you need to do when you get your practice started back up. And we want to make sure that you can reach out to them. You can reach out to us and we'll send it to them. So before we change slides over, everyone, I just want to give you a second to take a picture. And then Leah, you can go ahead and change it when you're ready. Thank you. You can continue to answer questions while we change the slides out.
Leslie, I'm going to turn it back to you for some questions. Those pretty much just the highlights of what I saw.
Okay, but one of the questions that came in was regarding pre-procedural, actually several questions, pre-procedural mouth rinses. And we actually don't have enough evidence to show that pre-procedural, whether it's Listerine or whether it's chlorhexidine or peroxide, there's been some evidence that it might help. So if it makes you feel better and any little thing that you can do to make a difference, I would say, use that if you want to, but ADA had something like that on their website and took it down based on the fact that there's a lack of documented evidence for that. How am I doing on time? Can I get another question or two?
I think we have time for a question or two. We're right at
Yeah,
right on
please
the
do.
point. Kay will advise us.
Okay.
Yes, keep going. I mean, I would love, I know we were a little bit starting late, so I would love to try to get as many as we can when we have you two here. I think, we haven't lost anybody, so let's just answer a few more.
Okay. Go ahead, Leslie.
Okay, so do isolation gowns need to be fluid resistant or non-fluid resistant? Well, they would be fluid resistant, certainly. And of course, aerosols are droplets and spatter that go onto the isolation gown. Hopefully your isolation gown is one that is disposable, but I've seen many that are like surgery isolation gowns that are changed in between patients. And then someone said, are we recommending spraying down a room and then using 2 wipes for cleaning and disinfection? Well, there's a place for sprays and there's a place for wipes. Sometimes you have to disinfect, for example, an impression or a prosthetic appliance. And so if you're using a wipe, that's kind of hard to do. So you need to use a spray. If you can avoid the use of sprays in a treatment room, that is better because you're going to be breathing in the aerosols in that room for a period of time, and it's not healthy to be breathing in. However, there's also nooks and crannies that we find in a treatment room. So with a wipe, you can damp mop over the top, but you might not get into the nooks and crannies where a spray can spray a stream in and lift out. Let's see if there's another one. We talked about informed consent. Someone asked about whether there was a fit test waiver for the N95 respirators. And I know that, that there's a waiver for annual testing, but not for the initial testing. And is the employer responsible for laundering scrubs and lab coats? Absolutely. That's been OSHA's position since 1991. How are we doing? Good?
Leslie, there's one question. Let me just go back real quick. It was, I'm sorry, now I've lost it.
I'll let you
So, here it is, Rella Christensen's webinar. I think we were both on that a couple Saturdays ago. And yes, Rella Christensen raised the point that we're right, the EPA doesn't test the products, but they're reviewing the information that the manufacturer has submitted, and that most of the manufacturers are using serum and not blood. And that's what Dr. Christensen and Rella, both of them are testing with blood in their test labs. So there is a difference. The only product that she recommended at this time was called BioSurf. So when you research that, you'll determine that that requires a different type of workflow because it's not pre-mixed in a wipe or a spray. It's a 2-step process where the solution has to come out of the container each time, the original container, and special different wipes are used instead of paper towels. What Dr. Christensen liked about that was the fact that it had a high ethanol alcohol percentage, and that's virucidal. And so that's a great claim as well. We need to go back and double check because I think it was on the EPA list. I haven't double checked to make sure it still is. And that being said, another consideration in using that product is what's the impact it's going to have on your equipment with that level of alcohol. So Leslie, go ahead.
And the conundrum is, what someone asked, if patient number 1 is asymptomatic with COVID-19, but has it and has dental work done, will patient number 2 be exposed from the aerosols from patient number 1? Is there a concern? And then what I would say is that as we make our soft rollout into returning to work, that we are minimizing the number of patients that we're seeing. And if we're working in one treatment room where we've aerosolized, perhaps we go down to the other side of the office and use the other treatment room or the other chair for the next patient. So we have a chance for those aerosols to settle out. And should the healthcare provider never remove a mask? Well, you will have to remove a mask to either change between patients, or if you're in limited or crisis capacity, then you just remember that when you do remove your mask, you want to make sure that you're removing that mask outside of the treatment room. You see, before we used to have to remove all of our PPE in the treatment room, and now we have to be mindful of what we could be exposed to. It's a new world with aerosols, and there are a lot of questions that came in regarding HEPA air filters and purifiers. And I'd like to address that. That's just a whole gigantic webinar all in itself to discuss all of those different options. And again, I'd like to see what the science is and instruct dentists to look at their own facilities, at their own practice, and speak with if they don't own the building, speak with the building owner to find out what could be done and what kind of systems. They're expensive, so we are talking about if you want to convert your treatment room into a hospital airborne isolation room, infection isolation isolation room. It may be that in a year or so, we have this under control and have the vaccination available and can resume a little bit more relaxed type of PPE and aerosol cognizance. We may not have to worry about aerosol transmission in the future. So another question that I had come up was on pediatric offices. They use nitrous oxide all day. And so they have a couple of different units and wondered to know if they could wipe down the hoses. Well, anything that nose mask needs to be either single-use disposable or sterilized between each patient based on the manufacturer's directions for use. And I spoke with the American Association of Oral and Maxillofacial Surgeons because I got that question a lot from surgery practices. What do we do? You want to make sure that you have either the disposable hoses or the sterilizable, the autoclavable type of hoses. And remember that can be a point of infection transmission as well. And just to speak a final word to the open bay style, you may want to consider doing like what they do at the markets where they have the plastic shield up. And it may not be a plastic shield, it might be a plastic sheet that you would use in construction when you're going to hang it from the ceiling, like when you're painting, in between some of the treatment chairs, or use every other treatment chair so you have that distance.
Wow. So thank you so much for, answering those questions. I know we have a lot more. And again, I know you guys are going to give some handouts, and then those handouts, we're going to have some directions on where they can go to get all their questions and all their answers. So with that being said, I am blown away with everything that you've done. And I hope you guys will come back and do it again, maybe in a couple of weeks, so we can keep them informed about what's going on. And also make sure that you guys both also give out a lot of CEs as far as on your own and training on your own. So please reach out. I know there's a shortage of you guys right now, right? There's not enough to go around, and you are working 24/7. So thank you very much for that. We really appreciate it. With everything being said, I just want to remind everyone again, we will get your CEs out to you. It takes about 30 days, so just be patient. If you have any questions, or if you just want to maybe shout out some things that you want to hear to us or give us some feedback, you'll see on the screen, it's at practicecoaching@benco.com. Please feel free to share. We want to hear from you. We want to know how we're doing. So please reach out to us. I also want to talk to you a little about some upcoming webinars. So definitely, I know that, you guys talked a lot about PPEs and where they're coming from and what to look for. Well, Rick Cohen is going to be giving us some really good information about that. He's going to be telling us about the trends and about what to look for, about what to watch for when you buy your supplies. He's also going to be telling us a little information about, the charges and why we're charging what we're charging. So that's going to be an amazing webinar. So if you want to, you can actually use your iPhone and you can scan the code and it will automatically take you to the registration. I will say this. We will run out of room, so the sooner you register, the better. So please make sure you join us. And again, that one's going to be tomorrow, but from 2 to 3 Eastern time. So we'd love to see you on that webinar. And then this is amazing. You know how we were just talking about design and how you were just talking about how you can close in a room and how you have to make sure that you do everything? Well, we're going to have a design person come on and really talk to us about, Melissa has a lot of background about, what we should do in an office and how we can make a dental office more user-friendly for everyone and a little bit safer. So she's going to be coming on, and then we're also going to have Manal on, who is a marketing specialist. And so she's going to tell us, how do we communicate all this new stuff to our patients? You've gone over a lot of stuff today, all 3 of you. Now we need to make sure that we get all that information out to our patients. So again, this is going to be an amazing webinar. It's going to be on May 6th from 2 to 4 Eastern time. So again, if you take a picture of the SKU, it will actually take you straight to the registration, and you'll be able to register from there. So, and then save the date. So we have several more. I don't want to go over all of them, but these are the dates we'd love for you to save. As you can see, Benco is doing the best we can to make sure that we take care of our amazing family, Benco family, as you get started back up. So please, Chuck, do you want to say anything to end it? You good? So please make sure, guys, you tune into these webinars, and if you have any feedback on things that you want to see, let us know. We're happy to take care of you. So with that being said, if you have any questions, please reach out to us. Again, I want to thank Tim, Linda, and Leslie. You guys are amazing, and we are so lucky to have you as part of our team. I don't know what we'd do without you. I'm sure you're going to have a lot of people reaching out to you, but please, thank you again. If you have any questions, please make sure you just send them to practicecoaching@venco.com, and we'll make sure we get them out to you. Tim will also be sending out all of the Q&A from his webinar, so we'll send that out to everyone. So thank you very much for attending, and we'll see you on tomorrow. Bye-bye.
Bye.
Thank you. Thank you.